Hello, welcome to Sonography Radiology Training Channel. This series of videos is about postpartum ultrasound findings. This is the second video in this video series with title of Postpartum Hemorrhage. The outline of this presentation includes introduction, incidence, definition and classification, etiology, and final teaching points. At first, introduction. Some amount of bleeding postpartum is expected and is normal. Therefore, visualization of a small amount of blood and debris within the postpartum uterus is a normal finding, and the amount of fluid or debris should decrease over time, as I explained in video 1. When patients have an abnormal amount of bleeding, pain, and or fever, then sonographic valuation is typically utilized to assess for etiologies such as retained products of conception. The incidence. Postpartum hemorrhage affects about 1 to 5% of deliveries and can be life-threatening. Definition and classification. Postpartum hemorrhage is the loss of more than 500 milliliters of blood after a vaginal delivery or 1,000 or more after cesarean section, which is the leading cause of maternal death worldwide. American College of Obstetricians and Gynecologists defines postpartum hemorrhage as blood loss which decreases the hematocrit level by 10% between admission and the postpartum period, or the need for transfusion after delivery secondary to blood loss. The postpartum hemorrhage is classified as primary postpartum hemorrhage, means in the first 24 hours after delivery, and secondary postpartum hemorrhage, means after 1 day to 6 weeks after delivery. Etiology. Common causes of primary postpartum hemorrhage include uterine atony, retained placenta, lower genital tract lacerations, uterine inversion, uterine rupture, and coagulopathy. Common causes of secondary postpartum hemorrhage include subinvolution of the placental site, placenta accreta spectrum, retained products of conception, endometritis, and coagulopathy. At first, uterine atony. Uterine atony, or inability for the myometrium to contract after delivery of the placenta, is perhaps the most common cause of obstetric hemorrhage. Because about 300 to 600 milliliters per minute of blood circulates through the term-gravid uterus, which is about 2 to 17% of the maternal cardiac output, uterine atony is a clinical emergency and, if not treated immediately, can lead to death. Risk factors for uterine atony include prolonged or precipitous labor, uterine distension due to multifetal gestation, polyhydramnios, fetal macrosomia. You can find full explanation about fetal macrosomia in this video. Fibroid uterus, chorioamnionitis, induced magnesium sulfate infusion, and prolonged use of oxytocin, retained placental tissue, and placental disorders such as placenta accreta spectrum, placenta previa, and abruption placenta. There are full explanation about these items in these videos. Coagulopathy, uterine inversion, and very high BMI. In certain instances, ultrasound can help to predict women at risk for uterine atony such as myomas, retained placental tissue, and abnormal placentation. Retained placenta was explained in video 1. Lower genital tract lacerations. Lacerations occur frequently in childbirth and can involve the perineum, labia, vagina, and cervix. Most lacerations will heal without long-term complications, but severe lacerations can lead to prolonged pain, sexual dysfunction, and embarrassment. Severe lacerations need to be identified and probably repaired at the time of delivery. Of course, genital tract laceration are clinically diagnosed by gynecologists and no need to imaging. Uterine inversion. Uterine inversion occurs when the uterine fundus collapses into the endometrial cavity, turning the uterus partially or completely inside out. There are two types of uterine inversion: puerperal within 6 weeks of childbirth and non-puerperal. Although puerperal type is a rare complication of vaginal or cesarean birth, it is a life-threatening obstetric emergency because if not promptly recognized and treated, uterine inversion can lead to severe hemorrhage and shock, resulting in maternal death. Spontaneous inversion of the non-puerperal uterus accounts for approximately 5% of all uterine inversions. It's almost always associated with a polypoid uterine tumor, usually a leiomyoma, but other tumors, for example teratoma or sarcoma, have also been implicated. Classification. Uterine inversions are classified by the extent of inversion and time of occurrence. According to the extent of inversion, we have first degree, means incomplete inversion. In this degree, fundus within the endometrial cavity. Second degree or complete inversion means fundus protrudes through the cervical os. In third degree or prolapsed inversion, fundus protrudes to or beyond the introitus. And in fourth degree or total inversion, both the uterus and vagina are inverted. Approximately 90% of uterine inversion are second degree or more. Classification according to time of occurrence, it's classified as acute, means within 24 hours of delivery, subacute more than 24 hours but less than 4 weeks postpartum, and chronic means 1 month or more postpartum. About 83% of cases are acute, 14% subacute, and about 3% are chronic. Pathogenesis. The pathogenesis of uterine inversion is incompletely understood. It has been attributed to the use of excessive cord traction and fundal pressure, famous as Creedy maneuver, during the third stage of labor, especially in the setting of uterine atony with fundal placental implantation. Hemorrhage may occur because the invaginated fundus may not contract normally and the inverted endometrium is stretched, which exacerbates bleeding from any areas of the placental separation. What is the risk factor for uterine inversion? There are many risk factors, including abnormal placentation, such as retained and or abnormally adherent placenta, prolonged labor, preeclampsia with severe features, and multifetal pregnancy. What is the clinical features of uterine inversion? The clinical presentation depends on the extent and time of occurrence of the inversion. Signs and symptoms include one or more of the following: mild to severe vaginal bleeding, mild to severe lower abdominal pain, a smooth round mass protruding to the cervix or vagina, urinary retention. In the absence of heavy bleeding or careful examination of the fundus, these patients may not be identified for days or weeks. In such cases, the uterus may become edematous and infected, and surgical intervention is likely to be required to replace the uterus because of normal postpartum cervical constriction. The diagnosis of acute uterine inversion should be suspected in postpartum patients with hypotension out of proportion to estimated blood loss and or when the provider is unable to palpate a normally positioned fundus on abdominal examination. Radiographic imaging, for example ultrasound, CT or MRI, is rarely necessary but should be used to confirm inversion when the diagnosis is uncertain and the patient is hemodynamically stable. Importantly, in patients with significant vaginal bleeding, treatment should not be delayed for radiologic confirmation. Uterine inversion can be a difficult diagnosis on ultrasound and often is confirmed with CT or MRI. Despite this matter, on longitudinal ultrasound scan, uterine fundus is upside down, famous as fallen fundus sign. This sagittal image showing the inverted fundus as a central crater-like depression. On transverse scan, a bull's eye or target-like appearance may be seen. CT and MRI. Although rare, the appearance is pathognomonic on CT and MRI. The uterus is upside down with the fundus in the vagina. As we can see in these images, the fundus is upside down within the fundus in the vagina. In this coronal and also in sagittal CT images, and another one in MRI, we can see the same findings in sagittal and also in coronal images. Also, the ovaries and adnexa are drawn centrally to the cervix, as we can see here. Differential diagnosis for uterine inversion. The most common considered in differential diagnosis is a prolapsed fibroid. Physical and ultrasound examination of the fundus help to distinguish these two entities. The fundus is centrally normal in contour and position with a prolapsed fibroid, whereas with the uterine inversion, the fundus is absent from its normal position or markedly abnormal, for example, cupped and smaller than expected. Uterine rupture. Most uterine ruptures occur in patients who have had a previous transmyometrial surgical incision, typically for cesarean births. Rupture of the unscarred uterus is rare, but the incidence is increasing and the risk of maternal and neonatal serious morbidity is higher than that after rupture of the scarred uterus. What is the risk factor for uterine ruptures? There are many risk factors. For example, exposure to uterotonic drugs, high parity, advanced maternal age, uterine anomaly, dystocia and macrosomia, multiple gestation, abnormal placentation, for example, placenta accreta spectrum, short interpregnancy interval. Other risk factors include trauma, such as a car accident or an obstetric maneuver, for example, external cephalic version, and also weakness of the myometrium, which it can be congenital, such as from Ehlers-Danlos type 4 or osteogenesis imperfecta type 1. Or it may be occurred, such as from prolonged labor and or use of uterotonic drugs. Is diagnostic imaging has important role in diagnosis of uterine rupture or not? For the pregnant patients with abdominal pain, hemodynamic instability, and a non-reassuring fetal heart rate pattern, stabilization and urgent delivery are generally indicated. In the rare stable patient with a subacute presentation, for example, no or mild abdominal pain, no or light vaginal bleeding, category 1 or 2 fetal heart rate tracing, ultrasound imaging of the abdomen may identify a defect in the uterine wall or another pathology accounting for the patient's symptoms. This transabdominal ultrasound image shows the empty uterine cavity, and also we can see a part of the fetus is lie to the left side of the uterus. Undoubtedly, the diagnosis of uterine rupture is a clinical diagnosis in most cases, and there will be no need for imaging. But in a woman who has a history of uterine rupture, there are many questions for the next pregnancy. and familiarizing radiologists with how to answer these questions will be useful. Now we can review these questions. What is the risk of recurrent rupture in next pregnancy? The incidence of recurrent uterine rupture is about 10%. The mean gestational age at the time of recurrent uterine rupture is about 33 weeks. But here there is an important question. What is the best timing for the subsequent pregnancy? An inter-pregnancy interval of at least 18 months for patients who desire pregnancy following repair of rupture of the unscarred uterus is recommended. Can we predict recurrent rupture? Scar thickness and integrity may be assessed by ultrasound examination in the future pregnancies. An intact and thick scar is reassuring of the integrity of the repair, and a thin scar or a defect is worrisome for recurrent rupture. Despite these qualitative ultrasound findings, the quantitative risk of rupture associated with scar thickness has not been determined, and there are no data for normal myometrial thickness at sites other than the lower uterine segment. Furthermore, patients with normal lower uterine segment thickness antepartum have gone on to rupture the uterus when in labor. Coagulopathy. Postpartum hemorrhage associated coagulopathy has been described as a form of DIC, where hemostatic changes are predominantly due to consumption of coagulation factors. Of course, this is a laboratory diagnosis. Common causes of secondary postpartum hemorrhage. Subinvolution of the placental site was explained in video 1. Placenta accreta spectrum and coagulopathy have explained before. Retained product of conception and endometritis will be explained in future videos, of course with God willing. Now, please pay attention to these final teaching points. Some amount of bleeding postpartum is expected and is normal. Therefore, visualization of a small amount of blood and debris within the postpartum uterus is a normal finding, and the amount of fluid or debris should decrease over time. Uterine atony is a clinical emergency and if not treated immediately can lead to maternal death. In certain instances, ultrasound can help to predict women at risk for uterine atony, such as myomas, retained placental tissue, and abnormal placentation. Radiographic imaging is rarely necessary for diagnosis of uterine inversion, but should be used to confirm inversion when the diagnosis is uncertain and the patient is hemodynamically stable. Importantly, in patients with significant vaginal bleeding, treatment should not be delayed for radiologic confirmation. Uterine inversion can be a difficult diagnosis on ultrasound and often is confirmed with CT or MRI. An inter-pregnancy interval of at least 18 months is recommended for patients who desire pregnancy following repair of rupture of the unscarred uterus. The quantitative risk of uterine rupture associated with the scar thickness has not been determined, and there are no data for normal myometrial thickness at sites other than the lower uterine segment. Furthermore, patients with normal lower uterine segment thickness antepartum have gone on to rupture the uterus when in labor. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.